Hello everyone, my name is Jen Nolan and I'd like to welcome you to the third webinar in Move Muscle, Bone and Joint Health 2018 Musculoskeletal Health webinar series. Tonight's webinar is on better understanding painful tendons in midlife and their management. Move Muscle, Bone and Joint Health has some great webinars in this first half year and the list should be on your screens now. You can purchase the webinars individually or as a series, and the recordings of previous webinars are also available for purchase at any time. I'm happy to announce that due to external funding, we are able to offer our next webinar on Tuesday the 29th of May free of charge. Before introducing our presenter for this evening, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time that can be read by our webinar organiser at Redback Conferencing. If you're listening via the phone, you'll notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions after the completion of his presentation, you can type questions for him at any time. Can I suggest that you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Standard Time. Also, I'd be very grateful to all participants to take a moment at the end of the presentation and webinar to respond to our feedback survey. Our presenter for this evening will be Professor Bill Vicenzino. Bill is the Chair in Sports Physiotherapy in the School of Health and Rehabilitation Sciences at the University of Queensland. He is also the Director of the Master of Physiotherapy Programs in Musculoskeletal and Sports Physiotherapy and of the Sports Injury Rehabilitation and Prevention for Health Research Unit. Bill's focus is on musculoskeletal health, pain and injury. He has received over $25 million in research funds and conducts clinical trials on treatments such as exercise, manual therapy, injections, advice and education, and orthoses and taping. He has communicated his research in over 200 peer-reviewed journal publications, 2 books, 35 chapters, and in over 300 podium workshop presentations. Without further ado, I'll hand proceedings over to Bill. Thanks very much, Bill.
Thank you, Jen, and good evening, everyone. I have to admit I was quite excited when I got the call from Move, the invitation from Move to do this webinar. Been pretty impressed by the way they've taken a positive stance on osteoarthritis, the positive messaging that they bring out, so I was only too happy to contribute. The discussion tonight is about painful tendons in midlife, and what I'm going to do is focus my talk on, I'd like to be able to move these forward. Jeff, my arrow isn't working. Why isn't it working? Are you there, Jeff? Okay, it is now. All right, thanks. Okay, so my talk tonight I'm going to break up into 2 parts. The first part's going to be a bit longer on tennis elbow, well, about 2/3 of the talk, and the second will be on gluteal tendinopathy. I've chosen 2 tendons to highlight a number of features that I think are important in management and understanding tendinopathy in midlife. These tendons are typically occurring in middle age. So the tennis elbow part of the talk. Tennis elbow, for those of you that aren't familiar with it, is essentially a clinical presentation, a clinical diagnosis. Presents as lateral elbow pain. Rarely does it spread beyond the elbow, the lateral elbow, but it can go down into the forearm. It won't go into the wrist or distally and won't come up the arm or into the neck. So we're talking about a localized tennis lateral elbow pain. The key presentation features are that the pain is aggravated or exacerbated with gripping activities and manipulating objects with the hand, and can be tested and with pain-free grip or grip dynamometry, which I'll explain in a minute. It is a clinical diagnosis. Most people would agree with this. The consensus is that imaging is not needed, and I'll come to a point in the talk where I'll explain where imaging may have a role. But essentially, it's a localized condition, lateral elbow. It is tended to push on, and patients will indicate it's painful when they shake hands and turn doorknobs and the like. It tends to present equally in both males and females. It is age biased. It tends to be a middle-age condition. So the kind of patient you'll be looking at is between 45, 55 years of age. If you have someone that's younger, they're likely to have some other condition around the radiohumeral joint, and later on they're likely to have some osteoarthritic changes. The prevalence rates can be as high as 15, 20% in activities or jobs, sports that require a lot of gripping activities. In some people, it can result in absenteeism for up to 3 months. Rarely does it go to surgery. And probably one of the reasons why most of us join these talks is that we all have memories of patients that have not got better or have come back and back with recurrences. It generally is an insidious onset, so the condition I'm talking about tonight is non-traumatic in nature, exacerbated by gripping tasks, may have come on after a bout of unaccustomed use, and generally is in midlife, but can come on in people that are in particular industries. I think 2 take-home messages for tennis elbow is that there are 2 clinical assessment tools that I think are mandatory to have. One is a grip dynamometer, shown here, to test grip in tennis elbow patients. The most sensitive position is the elbow extended, the forearm pronated. I do it in this position because it takes the weight of the dynamometer handles off the forearm, making it a relaxed position in between gripping. Pain-free grip, which is the onset, is gripping to the first onset of pain, is more sensitive to change and more characteristic of tennis elbow, so there are bigger deficits in tennis elbow. The other measurement, which I think is a very nice one, and those of you that have worked with tennis elbow will understand when we get closer to it, the patient-rated tennis evaluation scale consists of 15 questions. The first 5 deal with pain over the previous week, 0 being no pain, 10 being worst pain imaginable, for activities that aggravate the person and at rest. And then there's the functional disability part, which is 10 questions. Unable to do is the 10 side of it. 0 is no difficulty. There are specific activities that you will recognise are ones which are characteristic of patients that have tennis elbow. Then there are usual activities for work and grooming, etc. Recreation here. To score to end up with a final score, the functional scores are summed and then halved, and then they are combined with the pain scores to give you a score out of 100, with 100 being worst case scenario and 0 being no problem at all. So what I would like to do now is, most of my talk's about this notion of one size does not fit all. So I'm going to talk about some of our data and some of the ideas we have about how we would view a patient with tennis elbow as they walk through the door. I put this slide up to indicate that the paper has been published in Journal of Orthopedic Sports Physical Therapy. The whole issue is related to tendinopathy. So if I go back to that patient-rated tennis evaluation form and talk about one of our studies where we looked at thermal hyperalgesia in tennis elbow, what we did is we clustered something like 167 patients on the tennis elbow score, the PRTE, and came up with 3 clusters. The majority of them are in the mild to moderate range, but there is a percentage around about a quarter or so in the severe. Now just keep that in mind because I'm going to be coming back to this. So what we've done here is we've got a group of 160 odd patients which we've clustered on the patient-rated tennis evaluation. We then took measures of thermal hyperalgesia. This is essentially just where you put a thermode on the elbow or some other part of the body, increase the temperature, the participant will feel an increasing temperature, and they tell us when they first feel pain. And we can do cold pain hyperalgesia by just reducing the pain, the temperature until they first feel pain. So this next slide is a results slide of our 160 odd patients. Here we have the mean difference in degrees. We have heat pain threshold here and cold pain threshold here. But the diamond is the mild versus control group comparison, mean difference. The square is the moderate and the triangle is the severe versus the control. And what is remarkable about this slide is that in the most severe cases of tennis elbow, there is bilateral. So these are unilateral tennis elbow, and they have bilateral cold hyperalgesia, which is not present for heat hyperalgesia. So the more severe cases tend to present with cold hyperalgesia and high levels of patient-rated tennis evaluation score. So we've taken a prognostic approach to thinking about how we would manage the patient that presents to us through the door with tennis elbow. And we've gone about it in three categories. And the three categories are basically decided upon the effort and the resource we will put into treating them. So there's the low risk, which is the group that we saw just a little while ago over here. So the low risk, moderate risk, and high risk groups. So they're the severity of the condition. So they're differentiated on patient-rated tennis evaluation and on cold hyperalgesia. You might ask in clinic, could you test this? We're in the process of trying to get a clinical test. But for other areas of the body, if you take an ice cube and put it on the injured part or the sore part, the painful area for 10 seconds, and ask the patient to rate the pain they feel with that, if it's greater than 5 out of 10, they're more likely to have cold hyperalgesia and more likely to be severe cases. What our data found when we looked at 41 patient tennis elbows was that cold pain threshold was the only measure out of all pain threshold tests and psychological measures that we took, like anxiety, depression, kinesiophobia, catastrophization. When we put all them into a model, the only physical measure that came out as being predictive of a patient 2 months and 12 months down the track was cold pain threshold. So cold pain hyperalgesia, those people that feel pain in the presence of ice on their skin are likely to be worse down the track. And the other thing is that tennis elbow is a mechanical hyperalgesia, so cold pain threshold predicts mechanical hyperalgesia at 2 and 12 months to the tune of 52% at 12 months. So therefore, cold hyperalgesia detects those that are more sensitive to touch and mechanically hyperalgesic. So that's the linkage with the patient-rated tennis evaluation. There is other information that is, other people have found that if you have neck pain, you have worse outcomes at 12 months. If you have shoulder pain, you tend to be worse off as well. So we put that in the high risk category. So if a patient presents with a high patient-rated tennis evaluation, cold hyperalgesic, and have coexisting neck or shoulder pain, we're going to think a bit differently about treating them than if they're down at the low risk end. If people come along and have tasks that involve handling tools or loads as written on this slide, their odds ratios of having tennis elbow and more severe tennis elbow is raised. So we put them in the moderate risk group on the basis of the management approach we would take. We also put people that have low job control and low social support in this group, though sometimes further research needs to be done to elucidate where you would put those people. You would think they're more up there than here, but at current time we're suggesting they're here. And then there are other conditions like other neuromuscular impairments, weakness, and coexisting minor elbow pathologies. Something that doesn't show up that much in tennis elbow that does in other musculoskeletal conditions is psychosocial factors. There hasn't been a lot of work done on this. What we would presume, we are doing some now, we would presume that we would find some, just as we do in other chronic musculoskeletal conditions, that there might be some factors we need to factor into the high risk group. So what we propose is that these three categories we would manage somewhat differently, and I'm going to walk through how we would do that now and the evidence for it, because that's where most of our research exists. So if we have someone that's got no cold hyperalgesia, no other coexisting pain in the neck or shoulder, and have got a low patient-rated tennis evaluation, a wait-and-see approach is probably the best approach for them for a number of reasons, and I'll explain them as we go through. So generally, we would give them general advice to reduce and modify pain-provoking loads. We'd encourage them to keep moving within these limits and to have some self-administered medication, heat ice, braces, whatever they feel helps, they should use. There are two studies that have actually studied wait-and-see approaches, one here in Australia by one of my PhD students, now at Griffith University, Leanne Bissett, and Inke Schmidt in Holland. And essentially, we both did a similar kind of wait-and-see approach where we gave a patient a brochure, had a physio explain to them that the condition is self-limiting, it isn't something that goes on to be catastrophic, that there are some right ways and wrong ways to move. We demonstrated that to them. We emphasized that they needed to continue movement, and some movement is better than immobility, and that there are ways in which they could do that. And then we actually, both these studies are randomized clinical trials, and so the outcome measure we used, just to show you the results of those slides, was a global rating of change scale, which is seen here, completely recovered to much worse. Both of our studies dichotomized the graph to completely recovered and much improved. And here on this axis here will be the percentage of people that were completely recovered and much improved. And along here we've got the 3, 6, 12 out, 52 weeks time course of the study. So one thing that was quite amazing, that in two different countries, Australia and Holland, some 4 years apart, similar wait-and-see approach, almost identical trajectories. So for those patients that turn up for a clinical trial across the world by the looks of it, they will have a natural resolution if they're just encouraged to keep moving and not to exacerbate the condition. So at about 12 to 26 weeks, you're from 50 to something like 70% or higher chance of recovery. So that is quite an important thing to keep in mind when talking to patients with tennis elbow, particularly those down at the lower end of severity. If they don't have a requirement to use their arm a lot at work or in recreation, wait-and-see approach might be quite beneficial for them. Of course, there are a percentage of people that don't, and with those people there may be a trial of wait-and-see, 6 to 12 weeks, if no change, then to escalate to the next stage. Often what happens when patients go to GP, and we've published in PLOS One recently, looking at some audit material from 15 years of GP practice in Australia. What tends to happen is either wait and see or you'll be right, just wait it out approach, versus an injection and versus physiotherapy. So there's probably equal likelihood that a GP or in primary care patients will be directed to these one of these three approaches. It's been shown in a number of countries, if they go to a sports physician or sports physio, they're more likely to be recommended to have both injection and physio. I'm going to talk about injection now because it's a question that's often asked of me once people realise that I meet generally that I work in tennis elbow. It's a question I get asked: should I have an injection? So I'm going to talk about our trial. It's much the same as Ninke's trial from Holland. So we did a study where we randomised people to wait and see, a steroid injection and physiotherapy. The steroid injection was one injection as written here. And the trajectory for this was high success rate early, but 50 flip of a coin chance of success between 12 and 26 weeks, which, as you could see and as you remember, is somewhat different to the wait and see. So patients that get an injection from 3 months outwards are demonstrating delayed recovery. And more interestingly is they have higher rates of recurrence, over 60% higher rates of recurrence after an injection of steroid versus wait and see. So probably not a good option, and that's the data that I would recount to a patient, should I be asked. And these findings are not novel. They've been written before in clinical commentaries and case series of clinics way back in 1954 by Young et al., in fact. Then if we look at the physiotherapy intervention that we used, just to round off this clinical trial before I get back to one size fits all the prognostic story I'm telling you overall. So what this involved is 8 30-minute sessions of mobilisation, movement and exercise over 6 weeks. Now, I'd like to really emphasise that the physiotherapy is nothing without the exercise. The exercise is the most critical component. And one paper that I always come back to, there's 2 by P and Markey. This is a long-term study they did. What they did is they followed up over 36 months, 2 groups, randomized exercise or just ultrasound, and they randomized 16 to exercise and 14 to ultrasound. 12 were followed up, eventually came back up after 36 months in exercise and 11 in ultrasound. And as you can see here, significantly less physio and GP treatment required in the exercise group, fewer sick leave days, less pain on visual analog scale. But the most telling thing is that 45% of the ultrasound group, almost half of them required surgery, whereas only 8% or 1 out of 12 in the exercise group required surgery. They concluded there's no spontaneous healing. Now, some of you might be thinking, oh, hang on, your wait and see approach, some of them, 20%, were the only ones that had problems. The thing to remember about P and Markey's study, they did take the worst of the worst. These people that they're looking at here are the ones that hadn't got better after physiotherapy, after injections. All of them had Provi injections, after some had surgery, etc., etc. So exercise is a very strong beneficial treatment for long-term chronic tennis elbow. Let's delve in a bit to the exercise. To do this, I'd like to first talk a bit about the most characteristic part of tennis elbow, and that's limited grip or painful grip. When we make a grip, to grip a dynamometer handle, for example, we use the long finger flexors. If the force generated by the long finger flexors is not checked by the extensors, we will get a flexion of the wrist occurring. If you all were to clench a fist now quite strongly, you'll see that you have some extension of the wrist. If you then keep that grip and try to flex, you'll notice that you're unable to maintain the grip force. Okay, so biomechanically inefficient to grip in flexion. So you need a counterbalance of the wrist extensors to hold the wrist in extension. So that's a normal grip. There are some really interesting things that happen in tennis elbow patients, and I've got a few studies I'd like to talk about. First, pain-free grip. This is a study of 40 tennis elbow patients with one-sided tennis elbow versus controls. Grip strength on this axis. These are that control group, the 95% confidence interval for the males. Females, pain-free grip is, so we've got in controls, we have male-female bias, there's a sex bias there. Tennis elbow removes that. So pain-free grip is very sensitive to tennis elbow. It is also sensitive to change. Maximum grip strength is not. Maximum grip strength is more like the controls. And the one thing that we found interesting in our study is that the opposite side was somewhat stronger. That's not always the case. That was unique to our study. But the message out of this is pain-free grip strength is the measure to take, not maximum grip strength. This study here is one that Luke Heels did. He's now at Central Queensland University as senior lecturer. He did his PhD with us. What he did is he inserted fine wires into the wrist and finger extensors and wrist and finger flexors. And then we asked patients to grip 20% of their maximum voluntary contraction, so it was just a very light contraction, and it was pain-free. We asked them to grip, and then we measured the EMG activity that occurred when they did that grip. What we found was that the wrist extensors, relative to all the other muscles, were lower in activity. In other words, the stabilizers of the wrist, those that counter the flexion moment, were being activated less by the nervous system. Another study we did, confirmed an observation of mine, is that when tennis elbow patients grip, they normally grip with less extension than normal. So tennis elbow patients tend to grip in some flexion or neutral position compared to somewhat extended in normal patients. If I just park those two studies to one side, because I'm going to bring in another study by this gentleman here, he showed that in tennis elbow patients and recovered tennis elbow patients, that there was weakness of the external-internal rotators at the shoulder, as well as abduction, weakness of the wrist extensors and flexors, but only weakness of the finger flexors, no weakness of the finger extensors, no weakness of they were spared, they were relatively stronger. So the way I put this information together is that when we ask a patient with tennis elbow to grip, they don't have the capacity to stabilize their wrist with their short wrist extensors, they use their long wrist extensors, which are also increased in activity, and that is mechanically the more sound way to stabilize the wrist with the long finger extensors would be in a more neutral position. So what I'm trying to get across is that there's a muscle imbalance occurring and an abnormal grip pattern. So when we do our exercises, we focus on ensuring the patient understands they need to have their wrist in some extension. We give them exercises that couple finger flexion with wrist extension. We don't give them exercises that involve long finger extensors. So when we give them exercises, we get them to grip whatever they're exercising with, so that they are flexing using their long finger flexors while they're using their wrist extensors. And the whole idea of the exercise is to give them slow contractions, build up endurance first, and then get into more strength endurance later on in the program. A critical thing is to exercise an elbow flexion. Elbow extension is provocative. And if the patient has time, pronation and supination is useful to add in. And again, there's weakness throughout the upper kinetic chain with these patients. So 2 to 3 times a week, general arm strengthening, upper limb strengthening for 6 to 8 weeks would be very beneficial, particularly if they're weak or if they're weak in specific muscles. So worthwhile testing. Isometric exercises can be a way of starting off if they're very pain sensitive with isotonic exercises, but as soon as we can get to isotonic exercises, we do. Eccentric exercises are not shown to be any more superior than isotonic or isometric for that case with tennis elbow. And the key thing to take home with the exercises is that in the lower limb, the recommendation for tendinopathy is to keep it under 5 out of 10. With the elbow, you do to keep it under 2 or 3 out of 10 when you're doing the exercise and afterwards in the next morning. So the pain levels can go up when they're doing exercise, but only to 2 or 3 out of 10. Any more than that will tend to be provocative. The mobilization with movement that we use is one that the patient can actually do themselves. I don't have the time to delve into this, but you could find information on this and I can explain it later on if people require, and I can send you some references for it. But essentially, the mobilization movement is the patient and the physio putting a sustained lateral glide on the elbow while the patient grips the dynamometer. And there are some specific rules about how the technique is applied, and it's only applied if it can remove or increase the amount of grip the patient can do to bring pain on. So it's critically important that it's effective at reducing pain so the patient can exercise. And we also apply deloading tape, which has been shown to increase grip strength and pressure pain thresholds. And a study with SSI ultrasound showed that it reduces muscle stress within the deload region. So we use exercise, taping in severe cases, and mobilization movement to encourage exercise to occur. So the moderate risk group, we would invest this approach. And the results from our study was like this. So compared to steroid injection, the physiotherapy is far superior. It has less recurrence, quite strong effects, no different here at 6 weeks, and significantly better over the rest of the treatment. And the interesting thing is that the physiotherapy patients required the wait and see policy group and the cortisone injection group sought twice as much more other treatments than the physiotherapy group. We asked patients not to have other treatments, but we also questioned them at the end of the study to see who had gone off and done it, had other treatments. And the physiotherapy group had less need for other treatments. So sometimes I get asked, is it the mobilization movement or exercise? And we don't know. Mobilization movement has been shown to improve grip strength immediately, but there's been no study by itself in the long term. Exercise for tendinopathy is the key though. So physiotherapy we applied here was both. When we presented our results to sports conferences, sports physicians and sports physios told us, well, they combine injection and physiotherapy on the basis that, the injection will get you a really good effect early, and then in the long term, the physiotherapy will maintain it. So we did a study where we randomized people into steroid injection or placebo injection and into physiotherapy, as I just explained, which is the MEX here, which is mobilized manual therapy and exercise, versus no treatment. So it's a 2x2 factorial. We ended up with about 40 people in each group, and we had pretty good follow-up. To cut to the chase, this is the success profile again. So we've got placebo looking a bit like wait and see, steroid injection being successful early, then having this bit of a dip off here. Recurrence rate still high in the steroid group, but just injecting saline into the area also had a recurrence rate. So basically, the steroid is better than placebo early on, but not later on, and definitely not in terms of recurrence. Steroid is better than placebo early on, but not later on, and definitely not in terms of recurrence rate. So the idea for this study is to see what happens if we add MEX or mobilization movement and exercise to steroid injection. And what we found was there's no difference. It's almost the same kind of curve, and the recurrence rates are high. So now remember, the recurrence rate for physiotherapy is about 8%. So the steroid medication seems to negate the physiotherapy effect. The physiotherapy added no benefit to the steroid. If we look at the physio and the placebo, it looks a bit more like what we saw before. The recurrence rate is less. It reduces recurrence rate in the placebo injection, and it's a lot better than steroid and placebo. Particularly, the physiotherapy is all about speeding up the rate of recovery early for both this study and the last study. So the take-home message is short-term gains of steroid injections, long-term pain. There's a role for physio and exercise, and we would recommend this in the group that's moderate risk. In other words, they're not high in the PRT, but these guys have probably got the PRT is around about grading 33 out of 100 to 54, and they've got demands that they need to exercise to increase capacity of the muscle. If the wait and see group is no better over 6 to 12 weeks, as I said before, we'd flip them over to this group. This group here, if someone's in the severe group, they'll still need exercise, but they'll need a bit more cautious and more careful approach, treatment of the neck, elbow, medications, and psychological evaluation. Not that there's evidence for that now, but we know in chronic persistent pain that there are other aspects and complexity to persistent pain that need to be looked into. If they're no better after 8 to 12 weeks with either exercise or in the high risk group, then I think ultrasound imaging would be warranted, ultrasound or MRI. If tendinopathy is confirmed, well then we're looking at job, sport, reassignment and modification, or we're considering adjunctive pharmacotherapy, prolotherapy, regenerative type therapies might have a role to play here, but there's very little evidence for any of those and quite some consequences downstream for having them, not to mention the costs. If on ultrasound we find it's not tendinopathy and it's ligamentous or neural or osteochondral defect, well then other management would be indicated at that stage. Remembering we've got quite a specific condition going into this, so it's highly unlikely that it is this, but if they haven't improved with regular treatment, then they would need to be evaluated for this. So that was the tennis elbow story and the one size doesn't fit all. We've just recently got accepted, and I read the proofs today, of an RCT for gluteal tendinopathy. Gluteal tendinopathy is a very interesting case. I'm going to spend some time now explaining it, another 5 or 10 minutes, or probably 10 minutes to go through our study and some characteristics of gluteal tendinopathy, which I think make it quite an interesting condition and one that we should take more interest in. And like I said, you're the first group in Australia to see the actual results of this data. It will come out open access in the British Medical Journal within the next week or so, as proofs were just sent back today. So we did a study where we looked at education plus exercise versus steroid injection versus wait and see in this group. It involved two sites, University of Melbourne and University of Queensland. It won the first prize at the conference at the Scandinavian Sports Congress this year, early in January, I'm happy to report. It was funded by the National Health and Medical Research Council of Australia, as were my other studies. So gluteal tendinopathy is an interesting condition. It is quite prevalent in females, tends to characteristically occur around about the 50-year age group. And in a study in Holland, in general medical practice, they showed that the prevalence of gluteal tendinopathy was over 4 times that of adductor or patellar tendinopathy, over 2 times that of proximal hamstring tendinopathy or Achilles tendinopathy. It is the most prevalent condition, a tendinopathy of the lower limb presenting to general medical practice. As well as that, there was another study done in Australia that showed that the people with gluteal tendinopathy have worse quality of life than patients that are on the wait list for total hip replacements, and no lesser pain and disability, and worse job prospects. They were unable to find work at a greater rate than those awaiting total hip replacements. This here is a 0, and the 0 is up there just to highlight the fact that if we wanted to practice evidence-based practice in gluteal tendinopathy, this is close to what exists. A recent systematic review found 3 RCTs, 4 cohort studies and 1 case control study. The 3 RCTs examined corticosteroid injection and showed what we've seen before, short-term benefits, and Cohen showed that there's no difference if it was guided or unguided. So that's all there is. There's very little on anything else in terms of randomized clinical trials. And if that wasn't surprising enough, if you look at all the literature up until the end of 2017, there are more systematic reviews in RCTs. Now that is quite an indictment of a condition and the evidence base for it. Hence our desire to get in and evaluate this as prevalent, quite a problematic condition, and very little done on it. The surprising thing is that although the mantra now for tendinopathy rehabilitation is load management and exercise, there was nothing done that looked at load management, and only one quasi-randomized clinical trial that looked at exercises, but the exercises were not specific for the muscles involved or the impairments of the condition. So we set about to randomise a group of patients, just over 200, into education and exercise, corticosteroid injection, or wait and see. Our primary outcome points were 8 and 52 weeks. The protocol was published in the BMC Musculoskeletal Disorders. This is open access and registered before the trial commenced. So the classic presentation for gluteal tendinopathy is what our selection criteria were. So they're generally in females, although we recruited both sexes. So the age between 35 to 70 years was our selection criteria. We wanted people that had over 3 out of 10 pain and for longer than 3 months duration. So these are reasonably severe cases. Our diagnosis was a 2-stage diagnosis process. So they had to have lateral hip pain. The clinical diagnosis by a physiotherapist involved direct palpation of the gluteal tendinopathy. It had to evoke pain. And then one of a range of physical tests which we published, essentially tests which compress the gluteal tendons up against the greatest trochanter. So adduction and movements into flexion, external rotation, adduction, with or without contraction. A simple test which tends to be most sensitive with high likelihood ratio is just asking the patient to stand on one leg for 30 seconds. And if they have pain within that time, it's a high likelihood they have MRI tendinopathy. We have a study in British Journal of Sports Medicine that shows that. As well as a diagnosis by a physiotherapist, they were also had to have an MRI diagnosis by a radiologist who was blind to the clinical examination. We had some specific exclusion criteria. We excluded low back pain, sciatic or groin pain, and hip joint pathologies. So when you're thinking about the results of our study, it is quite a specific population. Okay, they might have had some low back pain and groin pain, but it had to be very minor. It had to be 0 or 1 out of 10. So that's the group that we selected for our study. So we commenced recruitment in March 2013 and closed out September 2015. We ended up with 204 people, 100 in Brisbane, just over 100 in Melbourne. On average, they are 55 years old, 82% female, which is quite characteristic, and they were on average overweight. The mean pain score on the previous week was 5 out of 10, and the median duration was 24 months. These patients had their pain for a minimum of 24 months, median duration of 24 months. We randomized them into education and exercise, steroid injection, and wait and see, which I'll explain to you now. The wait and see was a bit like the tennis elbow. We encouraged them to keep moving. We warned them against being immobile, but also we indicated that they weren't to go out and do activities that aggravated their pain during the activity or afterwards. There was an explanation in the pamphlet, and the physio walked them through what the gluteal tendons were and what their condition was all about. And we reassured them that the condition was not life-threatening, and that majority of people bounce back after having gluteal tendinopathy. The steroid injection was under guidance, ultrasound guidance, by a radiologist, and this is the injection Celestone or Conacort with local anesthetic. One injection only. The education exercise of 14 sessions over 8 weeks with a physiotherapist involving education and supervised exercise. The program education exercise was all built around the impairments that we'd identified on systematic review, and which are reasonably obvious to clinicians that see these patients. So abductor muscle weakness is a major impairment. The patients tend to have a pelvic drop to the opposite side and a lateral shift when they're in single leg stance. And in combination with that, they tend to, in gait laboratory studies, have greater adductor moments during gait. So the education and exercise is all geared towards addressing these impairments. So the education was about minimizing provocative loads, so minimizing direct pressure, so either by lying on the gradus canter, or having the thigh in adduction and flexion. So direct pressure, hip adduction, and sustained postures and stretches, the patients were educated about and asked to avoid in the short term. They are asked to be careful of walking hill stairs right speed where these were painful, and to be careful of gait which had excessive adduction, either walking up and down stairs or normally along the flat. All these were about minimizing external hip adductor moments. So any excessive hip adduction, trunk lean, body mass placement off to the side, the patient was educated about this. Education also translated into the exercise that they did. There was two components to the exercise. One was a component that focused on the pelvis femur orientation, and this is done in supine and in standing. These are two examples of what we use. Bridging is a very good exercise. So here we see bilateral progressing to unilateral, all about having the patient stabilize and control the pelvis on femur orientation. And then this is done in standing, bilateral weight bearing through to increasing weight to a single leg stance, and then to stairs with support. All this was about control while loading, and the level of the exercise was somewhat hard level, 13 to 15.5 E that we used, and no change in pain during or after exercise. Then we had the conditioning or the strengthening part, which targeted the abductor muscles, so isometric abduction, isotonic abduction in lying and standing, and then targeted spring resistance or elastic resistance in weight bearing was the treatment that we used. This had to be done to the heart at a very hard level, and pain was allowed with this as long as it was under 5 out of 10 pain during or after the exercise, and that they weren't exacerbated after the exercise. So we followed up on adherence with the program, and it was very high, mainly as a function of having 14 visits, we feel, to the physiotherapist. We're tenacious and following patients up, so our loss to follow-up is low. Our global rating of change for this study was an 11-point scale. We dichotomized very much better, and moderately better. to be success or a good outcome. And again, this scale here you've seen before, this is the percentage of success on this axis. 8 and 52 weeks were the primary outcomes, but we measured them also at other time points. And our wait and see group had about a 30% success rate at 8 weeks and 50% success rate at 52 weeks. And compared to the only other study that did wait and see, Brinks, our findings are much the same. So that is comforting to know and looks like it's a consistent finding. If we look at the steroid injection at 8 weeks and at 52 weeks, there's about a 60% success rate. Of course, at 8 weeks, it's better than wait and see. Risk difference around 30%, but there's no difference at 52 weeks. And this is similar to the Brinks study as well. So 2 studies done independently, quite a characteristic response profile of wait and see and steroid injection. If we look at the education and exercise group, there's around about an 80% success rate at 8 and 52 weeks, quite a bit better, 30% at 8 and 52 weeks respectively in risk difference between the two, quite low numbers needed to treat at 8 weeks. And when we look at wait and see, there's about a 20% risk difference. So, and the NNT is quite substantial as well. So the physiotherapy, the education exercise group outperformed both other treatments at 8 and 52 weeks on the global rating of change score, as seen when all the data is compiled onto one slide. Interestingly, we had no adverse events reported. We sought this through questionnaires and through the normal reporting mechanism. And when we asked the patients at the end of the study to tell us what other treatments they'd sought, the education exercise group had only sought 5% more, and that's much, much less than the wait and see and steroid group that was up around 25-30% mark. So there's an indication that the education exercise left patients a bit more satisfied as well. We also measured the other primary outcome as was pain imaginable, as I think most of you would have used. And what we see here is that the real substantial differences between education, exercise, and wait and see, all these time points, all these interventions at 8 weeks are significantly better. But we're getting down to 1 for education versus steroid injection, so that's arguably not really meaningful. And out at 52 weeks, there is a difference between wait and see and education and exercise, and steroid injection and wait and see is not different. Education and corticosteroid injection is different. So I'll just repeat that because I've got a bit carried away. So wait and see is different to both other treatments, and steroid is no different to oh dear God, I really have got confused. Take 2, sorry. This is education and exercise, so it's much better than wait and see, no different to steroid injection. So the big difference at 52 weeks in the pain score is that there's no difference between steroid injection and education and exercise. Very sorry about that. So the take-home message there is that at 8 and 52 weeks, education exercise seems to be the most beneficial. Wait and see is probably not something we would be looking at, although if we look at a prognostic approach as we did for tennis elbow, there may be some patients. And steroid injection probably is something that we would not go to first off. Like I said, British Medical Journal has accepted and will publish the paper online open access over the next 2 to 4 weeks, I hope. And all the details could be found online. You could email me or follow me on Twitter, because once it becomes live through BMJ, I will actually post a tweet. So just to wrap up, a couple of points I wanted to make. Tennis elbow and gluteal tendinopathy tend to impact quite substantially on patients. Tennis elbow and gluteal tendinopathy, a steroid injection is not the way to go as a first treatment for gluteal tendinopathy, and probably seldomly or never in tennis elbow. Exercise seems to be beneficial in both tendinopathies, but only on the basis that the patient has education and supervision through the education and exercise. They're the messages that would come out of this. And finally, there probably is a role for using some measures like the patient-rated tennis evaluation, maybe cold hyperalgesia, and some other indicators to parse out those patients that can get by without too much intervention and manage nicely, maybe through advice through websites like Move, and others that really do need to exercise or have more detailed interventions. So I'd like to wind up there. Thank you very much for attending and hand it back over to Jen. Thank you.
Well done, Bill. You've got through an amazing amount of information there, so in a fairly restricted time. So thanks very much for a very sterling effort. We've got a couple of questions, and I urge everyone to type in their questions now if they have any. A question that came early on, Bill, in relation to your section of the presentation on tennis elbow was in relation to the cold reaction or response to cold hyperalgesia, and just wondered with regards to the age of the subjects. I think this was in the Coombs et al. Study,
yep.
And just wondered what the whether there was any change to the response to cold hyperalgesia in midlife.
We generally have a look at basic demographics like sex, age, duration of the condition, and age didn't come up as a prognostic factor. But bear in mind that tennis elbow is pretty self-selected to a narrow age group just by definition. So we're only looking at about most of our patients within 2 decades, 40 to 60. I'm not too sure. You would expect with age, all hyperalgesia will change. Probably it will become more prevalent, but I'm not aware of that for this population. So age wasn't a confounding factor in our data, but that may not answer your question more globally in terms of cold hyperalgesia and age.
Also, a couple of questions about dry needling. Just your view in relation to the use of dry needling as an intervention, as one of the physiotherapy interventions, along with exercises and MWM.
Yep. I found it quite interesting in the study that we had a placebo injection. That's the closest I've come to studying dry needling in tennis elbow. That there was a higher recurrence rate, 20% compared to 5% in physio. So, and all we injected was a little bit of saline. It was only a very, very small amount because we didn't want to cause any stretching of tissues. So dry needling is probably, so as much as I can talk about evidence that we have, there's no evidence that sticking a needle in is going to be beneficial, and that would be the placebo group that we had. By and large, anything I believe that is passive that the patient cannot do to themselves is probably something you would not do with patients with tendinopathy. The active approach where the patients learn about the condition and then know how to look after it and then gain capacity in the muscular tendon junction and the muscular tendon unit is the way to go. Dry needling and passive interventions tend to be contra to that, tend to decrease self-efficacy, and is not something I would recommend. We did a study on dry needling for Whiplash and showed that it was no better than placebo. And that's the only study I've been involved with dry needling. So I'm not a fan of dry needling. I think we should stop doing it, to be blunt.
Okay, another question in relation to gluteal tendinopathy. Does therapeutic massage of tight IT band help to relieve the symptoms?
Simply, I don't know. I think there's an over-preoccupation with tight structures generally. I think the big problem here is you've got a weakened, very much weakened gluteal tendinopathy, abductor unit that abducts the hip proper. If you then go and stretch the ITB, you then got nothing that holds the pelvis up on the femur. So I would encourage more the strengthening and the building of capacity of the active abductor muscles on the basis that the patient understands the pelvic femur alignment, and leave stretching way down the track. The study I mentioned, which was a quasi-randomized clinical trial that didn't show any benefit of their exercise, had stretching in it. Another thing with stretching, it's very hard to stretch ITB and not compress the gluteal tendons. So I guess that's why people then massage it. But massage in itself is another passive intervention that if the patient can't do, is probably something I'd leave way down the track in priority.
And Bill, do you believe the large anecdotal emphasis on gluteal medius is appropriate?
I don't understand the question, sorry.
If I could ask Megan to maybe clarify that question, that would be great. A question with regards to information about plantar fasciitis. I mean, I guess for everybody, you very kindly provided your email there, Bill, so if someone wants to maybe pursue some information in relation to other conditions, I'm sure they can do that. A question, I heard that de Quervain is more like a tendinopathy. I know you haven't addressed that, but have you found similar results where you rest then exercise versus injection?
I don't have much experience with de Quervain.
Versus injection.
I don't have much experience with de Quervain, unfortunately. With de Quervain, I think there is a stage which might have inflammatory pathology, which is different to the tendinopathies I've talked about. So an anti-inflammatory might well be useful at the right time. Judicious use by a qualified rheumatologist, sports physician. Exercise and education, I think, will also need to go along with that, so patients understand aggravating activities, how they can deload and reload without exacerbating their condition. When it comes to the plantar fasciitis, do please email. We have some studies in that, and I have a PhD student in Denmark that's doing research in that. So if you hit me up with that by email, just make it really short so I don't miss it and that I can attend to it. I'll get back to you within the next couple of days.
Also, another question, should we still incorporate eccentric tendinopathy? Do you believe gluteal medius plays a crucial role? Oh, this is Megan just clarifying that previous question.
Okay, so there are two questions that have come up. The eccentric exercising, I don't think, offers any more benefit for both these conditions than good high-load isotonics that involve both concentric and eccentric. The eccentric exercise is likely to be beneficial where you have tendons that require large amounts of energy absorption under quick loading. So the eccentric would be a precursor to doing reactive strengthening and then rebounding type activities. So Achilles, patella tendinopathy would be more, but they tend to be, that kind of approach would be more for the athlete and the younger person. In terms of the gluteal tendinopathy, there is evidence that the pathology in lateral hip pain or the greatest kind of pain syndrome essentially is glute med and glute minimus tendinopathy. All our patients had to have MRI evidence of tendinopathy. Some of them would have had bursal inflammation as well, and that those three structures are what signify gluteal tendinopathy as a diagnosis. So glute medius and glute minimus are, really important pelvis, thigh abductors and control the whole body weight when standing on one leg, along with other synergistic muscles, but they need to be a focus of interventions in this condition.
Yeah, thanks for clarifying that, Bill. I confused two questions there in the rush to sort of try to get through them. One last question here. Would you ask the patient to do any other blood tests or investigations to find out the underlying medical or whether there's any autoimmune conditions which may be causing tendinopathy? Okay,
so this is very critical. So the one thing that I didn't go through is all the exclusion criteria in our studies, but, if on examination there's evidence on questioning of sinister pathology or potential for underlying sinister pathology, there is no doubt that the patient should be counselled and referred off to the general medical practitioner to actually have those things followed up. So things like night pain, pain that is not directly related to mechanical loading and stress. Other phenotypical things, like people might have other signs, that really high BMIs, a whole lot of other conditions, diabetes, all those things. If they come along with the patient, which they tend to do in midlife, the patient does need to be looked at holistically, and general medical practitioner involvement, I think, would be critical in them. So that's a very good question. So I should have caveated my talk by saying, this is all done. My talk is all on the basis that I'm talking to a clinician that has an ability to observe and ask questions of the patient to rule out sinister pathologies before delving into these conditions here. Very good question. Thank you for that.
All right, and thank you, Bill, for what was a very generous and incredibly comprehensive presentation tonight. If I could ask everyone to now, the exit survey for feedback regarding this webinar is on your screen. I'd really appreciate if you would just take a moment to respond to those questions. Once again, Bill, thank you so much to everyone who's joined the webinar tonight. Thanks also for joining. We're just a tick over 8 p.m. Eastern Standard Time, so we'll close the webinar for tonight, and you will be receiving a copy of the recording and the presentation in the next few days. So thanks, everyone, and good evening. Thanks again, Bill.
Thank you. Thank you.